are just a few that may have some relevance to people in this room. But the two that I want to focus on are the next two. Medical Homes Pilot Program for persons with chronic conditions for the purposes of increasing access to comprehensive community-based care. This concept has been evolving over the last 10 years and builds on the practice of patient-centered care, which many of us have heard about. A patient-centered medical home is a model of measurable care provided by physician practices that, and this is a quote, strengthens the physician-patient relationship by replacing episodic care based on illness and patient complaints or just treating symptoms with coordinated care and a long-term healing relationship, close quote. That is actually from the National Committee on Quality Assurance, which is one of the accrediting bodies in DC for the patient-centered medical home. Some elements of a medical home include enhanced access and communication for and with patients and their families, patient tracking and registry functions, care management, patient self-management support, electronic prescribing, performance reporting and improvement, and advanced electronic communications, and the list goes on. If you haven't yet read it, I recommend Atul Gawande's article that describes a medical home primary care clinic in Camden, New Jersey. The article is called The Hotspotters, and that is the latest term. I mean, 3 times yesterday in 3 different meetings I heard that term uttered. And this article is in the January 24th issue of the New Yorker. Please read it. The other provision that I wanted to talk a little bit about is the Accountable Care Organizations demonstration program that will reward health care providers who are organized into groups or healthcare organizations with some level of vertical integration or cross-provider relationships. And we're hearing where there might be opportunities here. To be, quote, innovative in the drive toward achieving 3 goals: providing better patient care, improving population health, and lowering costs without denying needed care or harming anyone. And that's a quote from CMS. Like the unicorn, no one has ever seen an ACO or accountable care organization. But the principles that undergird it build on those of the medical homes model and require some of the same functions and aspects of care, which will need to be tightly managed across the population served by the ACO, Accountable Care Organization. This strategy shifts the responsibility from insurance companies managing care to that of healthcare providers managing the care of patients, which, in my opinion, is where it should have been all along. To undertake either of these, healthcare providers need health information technology to establish registries, because it's a requirement of the federal government, to systematically target what they do, who they do what to share relevant information across providers and systems, including communities, so that patients get and do the right things at the right time, and measure quality and cost in ways that can be proven to the payers. Fortunately, New York's healthcare world is way ahead on this front. Over the last 7 or 8 years, which accelerated in 2008 when the federal stimulus package put upwards of $80 billion into HIT and funded the Office for Health Information, healthcare in New York has been electronicizing. For example, New York City Department of Health and Mental Health has been helping physicians' offices set up electronic medical registries through its primary care information program. And I'm pleased to see Tom Cannell from Department of Health here today. I'm sure he will correct me because I don't always get these things right. But he's been working on this stuff for the last 3 years, and now has been working on a project with us with a NORC program and a physician's office to see if we can't have some information exchange and connectivity going on. The Regional Health Information Organizations, or RIOs, have been started across the state so that patient information is shared across providers at the point it is needed, and David is going to talk about some of that, I believe. And patient portals or electronic health records are making it easier for computer literate patients to make appointments, ask questions, and get answers back, and access patient education and self-care management information. And who knows, maybe one day there will be a community portal, that's a dream that we have, for community agencies to coordinate care with physicians' offices or receive the handoff from the hospital, home care agency, or nursing home. It's a dream. And how many of you here know that there are over 300 physicians in practices in Brooklyn who are already accredited through NCQA as medical homes? Surprising, right? But it's happening. At the same time, change has been happening in how NORC programs practice, shifting from reactive to systematic and targeted practice. Through the funds, Health Indicators and NORC Programs Initiative, which was funded by DIFTA, NORC programs are now able to identify the key risks to healthy aging in their communities, target their efforts using an electronic registry of clients with diabetes, heart disease, or an increased risk for falls, and conduct quality improvement interventions on the things that are actionable by NORC programs while adhering to standards and guidelines to measurably improve the management of these conditions. And NORC programs, I think, are positioned now to align with the changing world of health services delivery. Moving forward, I think there's lots for all of us in this room to talk about, and the time is right to get started. Hospitals and other healthcare providers are going to be held accountable through readmission penalties for the before and the after in a patient's healthcare event. For the first time, they will need to pay attention to community organizations that have long played a role in the day-to-day lives of seniors. They will need to go beyond the marketing and health fair activities, and we will need to go beyond it as well, that have low return and little, if any, benefit, and make meaningful, substantive connections to the community. It may be in their interest, as they try to better manage care, to put some strategic resources in a NORC program. Community-based organizations are at a critical point in time. It is unlikely that aging services will see any new dollars in the near and not so distant future. We run the risk of becoming irrelevant. I think we have an enormous opportunity before us to establish new roles as partners in helping seniors and the healthcare system manage and maintain health, and we need to rise to the occasion. Hospitals, physicians, and health plans will increasingly look to the community care system to partner in caring for the frail elderly. They'll be much better able to share information with us, but they will expect us to deliver responsive services to our shared clients or patients, as well as reciprocal information. Starting with transitions, information will need to be exchanged about a patient's discharge. I think, what was her name? The woman. Phyllis said it better than any of us could. We will need to understand what each sector does and what each sector will need to accomplish the common goal. Together we will need to answer some questions, and among them, what information is needed, by whom, and at what point in time? How will information exchange occur? What mechanisms, high-tech and low-tech, should be used so that the receiving organization, whether it's a nursing home, home care agency, or community-based organization, has the information needed to take action, and so that the number of people falling through cracks is kept to a minimum. This is just the starting point of questions. So I think we're living in a very scary but exciting time. None of us really knows what this will all look like when we are done. Maybe David does. But make no mistake, the world is changing. And today has been designed to get the conversation going, as Bob said, between the healthcare system and the community-based system in Brooklyn. Churchill, I think, actually said it best as Britain was being bombed. PR, you know. And he said, as Britain was being bombed, this is not the end. It's not even the beginning of the end. But perhaps it is the end of the beginning. So let's get going.
Yay.